Good morning, everybody. I'm Kuen Chow. I'm a respiratory and sleep physician and work at Macquarie University M&D service. Thank you for giving me this opportunity to present my PhD study, which I have been conducting the last 3 years. This is the list of disclosures. I'd like to acknowledge that ResMed provided the equipment for my study, and I received the award for traveling so that I can attend the conference this year. Now, a bit of background about non-invasive ventilation, what is also known as NIV. What you can see here is a patient lying flat, and it's surrounded by a chamber. This chamber is known as the iron lung. This iron lung was first developed in the 1930s to help patients breathe as a breathing support for patients who had respiratory muscle weakness that was caused by polio. Fast forward that now to the 21st century. As you can see, the ventilator, it's a portable ventilator, the size is significantly smaller. So now the breathing support is provided by the ventilator through the tubing attached and is to the mask of the patient here. For my study, I used this particular automatic ventilator that works in 2 ways. Firstly, it provides a positive pressure to keep the upper airways open. And it also delivers a set lung volumes to enable optimal breathing support. Now, as with any 21st century technology advancement, this portable ventilator also comes with internet connectivity. So currently, the literature tells us that NIV setup for M&D patients typically occur in a hospital setting, and it can take up to a week of hospital stay. It is not very clear whether an outpatient clinic set up using the NIV can be beneficial to M&D patients. So for my PhD study, I looked at whether I can transform hospital admission into an outpatient setting and assess a feasibility model using the outpatient clinic setting and also the portable ventilator that had the internet connectivity. I reviewed the NIV therapy adherence rates of the patients, and I also considered the issues of care required for this setup. My study was conducted at Macquarie University M&D service, and I had ethics approval. Patients with confirmed diagnosis of MND, as well as a history of shortness of breath, were considered. They were included into the study if they had an abnormal oximetry tracing. What you can see here is an abnormal oximetry tracing. An oximetry measures the oxygen saturation via a finger probe attached to a patient during their sleep at night. It is considered to be normal if the oxygen saturation remains around 95% consistently throughout the night. You can see here the trace is abnormal because there are several occasions where the oxygen saturation has dropped below 90% for more than 5% of the total recording time. This is the study timeline that I'd like to introduce you to. So T0, T1, T3, and T6. T0 is where I've labeled it as non-invasive setup. T1, T3, and T6 signifies time at follow-up at 1 month, 3 months, and 6 months. This follow-up in care is actually quite standard for any patients who are commenced on NIV. I'll go into more detail of the setup later. The primary aim of my particular study is to see whether setting up the NIV as an outpatient actually can translate to the patient using this machine at night, asleep on the ventilator. Now, the outpatient NIV setup model that I used takes about 90 minutes to complete. I usually encourage the patient and the carers or family members to attend this consultation. During this respiratory consultation, I conduct the mask fitting as well as the ventilator education and care. In this 90 minutes, there's also time for about 20 to 30 minutes of what I call it as a familiarization period, where the patient is lying flat and getting used to the sensation of the ventilator working. If I find that the patient is quite comfortable at this stage, sometimes I get the opportunity to fine-tune the ventilator adjustments to their ventilation needs. And ultimately, when everything is all said and done, and I feel that the patient is confident, they're discharged home with the equipment as listed, as shown, including an oximeter module. So here we have the patient is with a desired outcome of falling asleep, breathing on the ventilator at night. And I'm at my desk wondering what the patient's doing. We have internet. So what we do have is that this particular machine transmits the information up into this fabulous internet world, and it transmits the information back into my laptop. And what I can see is how many hours that the patient has used overnight. I can monitor the progress, as well as the tracing of the oximetry tracing. And with this, with technology, I'm able to then manipulate the ventilator setting and send it back through the internet that goes back to the patient's machine. I don't do this without telling the patient, of course. There's always communication between me and the patient, and we communicate often by telephone. So I also assess the number of times of the telephone interactions I've had with the patients. So what did my study find? I recruited 9 MND patients, 5 male and 4 female. 3 of them had bulbar onset disease, and the remainder had limb onset disease. The median age was 58, and they were very well nourished. The revised ALS functional rating scale was about 37, with the maximum score of 48, indicating that this particular group of patients had mild to moderate degree of functional impairment. 3 of the patients had to travel more than 200 kilometers to attend the Macquarie University review, and this again highlights the use of internet connectivity. Now I'm going to use this colored wheel to indicate the diverse characteristics of this particular group of patients. In this group of patients, they all had normal blood gases, they had mild breathlessness, and there was also a moderate degree of respiratory function impairment. But almost every single patient in my study had severe sleep disorder breathing. Now I'm going to go through a couple of graphs from here on, and I'd like to introduce you to what this scatter plot is. A scatter plot graph. Each of these dots represent a data point for a patient. For instance, this patient here took about 8 days to establish more than 4 hours of use within the first month. Now, the average time that it took for my particular group for the patient to get used to the ventilator that had to be more than 4 hours per night was 3 days from the time of setup. Again, another scatter plot graph. This graph shows the number of phone interactions that was had between myself and the patients. Again, 2 patients required 6 phone interactions, whereas only 2 patients here required 1 phone interaction. There is a diverse or a range of number of phone calls. But what you can generally see as well, 2 things. First of all, that in the first month, there was a lot of phone calls. But as with time progresses, in the 6 months, there's been a decline in the number of calls. And there was a significant difference between the first month and at 6 months. This is a column graph, again, showing the number of calls as well as the types of calls generated. The number of calls for the first month in total was 28, and it dropped to about 4 by 6 months. The bulk of the calls were initiated by myself, and it consisted of phone calls that was related to the changes in the pressure settings, mask fitting issues, as well as general, hello, how are you going, how are things at home, phone calls which I labelled it as general. I'll go into depth about the complications phone calls, but you can see that again, the numbers dropped, and there was none in the 3rd month, and there was 1 in 6 months. I've listed here the types of complications that were encountered by my group of patients. Now, these complications are fairly common and not unusual. And you can see that with conservative management, reassurance, that a lot of these problems could be resolved. I suspect that because the patients had direct contact to me and that they were able to voice their concerns early, that perhaps the uptake of NIV therapy might have been improved as well. At around 6 months, it is not unusual to have issues related to the equipment, but in the first month, it's usually what's termed as complications tend to be related to the pressurized air being blown into the nasal passages. So this next scatter plot again shows the number of adjustments that I made for the patient in my study. Again, the most intense month was in the first month. So here we have this patient required 4 changes remotely. 3 patients did not require any changes, but the trend again, there was a significant decline. There's a lot going on this graph, so I'm going to go through it very slowly. So this scatter plot graph shows the results of the patient's adherence. On the x-axis is what I've described as divided into T1, T3, T6, which is the time of follow-up for the patients. And the y-axis here shows the average number of use of the ventilator per night. This is calculated from the machine downloaded through the internet. First, I'd like to highlight that in the first month of follow-up here, all 8 patients were able to use the ventilator for more than 4 hours per night. Now I'm going to highlight another patient here, dotted in green. Unfortunately, or I shouldn't say unfortunately, this patient took a bit longer to get used to the machine and only had an average use of 1.5 hours per night. But you can see I followed her progress. It jumped from 1.5 hours to nearly 6 and then 10.6, almost above the average range for the population in 6 months. The trend here that I see is that the median hours used per day for my particular group of patients increased over time. And again, there was statistical significance between the first month and the 6th month. Now I'm going to go through the next 2 slides. The next 2 slides summarizes the comments that the patients had about their opinions on the use of NIV therapy. Generally, I won't read all the comments out. The comments were fairly positive, with an overall feeling that there has been an improvement in their general well-being, breathing, and sleep. Comments such as breathing better and able to sing in church, uninterrupted sleep, and able to walk 5 kilometers and continues to play golf, shows that the NIV therapy really made a difference to the patient's life. There were also some negative comments listed here. And although it's listed as a negative or even a neutral comments, I suspect that these comments were probably a reflection of the progressiveness of the disease and perhaps that the changing nature of their breathing requirements occurred over time as well. So in conclusion, the outpatient NIV setup model is feasible. It's feasible for MND patients with breathlessness and sleep disordered breathing. The initial adaptation occurred early and the adherence rate occurred over 6 months. It continued to increase. So this model of care in starting NIV therapy bypasses the need of a hospital admission and avoids that waiting for a hospital bed period of time. It means that NIV therapy can be started without delay. The use of this particular automatic ventilator with Wi-Fi connectivity allows me to be proactive in the management of patients' ventilation setting And it means that patients' care can be individualized. I'd like to acknowledge my PhD supervisors and my MQ research groups here for providing me with the support and guidance in my study. And lastly, I hope you've learned something from my presentation today, because I'm going to present again on Friday with a different aspect to my study. Thank you.
So thank you very much for your presentation. Does anybody have any questions they would like to ask? Just over here. You can see.
Thank you for your work. It's really nice to see that the adherence rate at home increases over the months. I was just wondering, did you also compare it with the adherence rate in clinic?
That's a very good question, because that's the next part of my study. So that's actually an ad hoc analysis. So I don't have that data to reveal here yet. But that's a good question. It's been looked at in my study.
Okay, thank you. Any other questions?
Thank you for that excellent baseline study. You mentioned when you were talking that patients or people were lying flat, but in the photo you actually had the head elevated by 20 to 30 degrees. Do you have any recommendations, or what's the feedback about actually lying flat or sleeping with the head up at a certain level?
Okay, thank you for that question. I think you might recognise that's actually a photo of myself for copyright reasons. And the reason why I wasn't able to lie flat is because if I lay flat, you can't see my face, and the ventilator was in the way. Now, the recommendation that I have for my patient is actually for them to lie at whichever position that's most comfortable for them. And I think, as we have heard this morning about, making it relevant to the patient's needs is actually very, very critical. Although for most of us, lying flat at night to sleep is comfortable, but for certain patients, when they've got all the disabilities and the impairment, it becomes quite uncomfortable. So I actually will titrate the ventilator needs to whatever position that they'll find themselves comfortable in at night when they're asleep.
Okay. I've got one more question. I've got one here and one over there. I think we'll have to leave it at two.
Pete Allcroft from Adelaide. Thank you for that presentation. These all had normal blood gases. How do you envisage monitoring with abnormal blood gases with markedly elevated PCO2?
I know that I mentioned that this particular group in general had normal blood gases, while in fact 2 of the patients had abnormal blood gases with a PaCO2 of 45 millimeters mercury. For one of the patients, I was able to reverse that back to normal, but for the second one, I wasn't able to. So I'm still following that through to see the progress. But I think overall, my message is you don't wait for them to develop respiratory failure with hypercapnic or high levels of carbon dioxide before initiating NIV therapy. And I'm not sure whether that's coming through on my presentation today, because there's so much to cover, and I'm trying to make it as practical so that you can take home a learning lesson from my particular study.
Interested in how you are going to monitor remotely the improvement in the gas exchange over time, because you're monitoring oximetry, but
Yep.
But you're remote, and we can't use transcutaneous, obviously.
So for my study, I did follow their PaCO2 level, the carbon dioxide level. So when they come back for follow-up at times 1, 3, and 6 months, I actually took more blood gases then. There is the option of also recording the transcutaneous measurement of carbon dioxide, although that's not as accurate and there's issues with consumables there. I think ultimately arterial blood gases is the more definite and clinical way of monitoring the progress.
Thank you. Just one more question.
Thank you for your presentation. I probably jumped the gun because
I can't find you. Where are you?
I'm here. Just in relation to the population that you studied, did many of them or any of them have any oral secretions, or were they eliminated from your study?
No, I did not eliminate anybody from my particular study.
Right.
So secretions wasn't an issue in my patient cohort, only because I think a lot of the patients that came to my study were what we considered an early phase, or were newly diagnosed motor neuron disease. Having said that, there's 4 patients who had very abnormal respiratory function tests as well. But it may well be that with this cohort, secretions wasn't an issue. But I do manage them separately as well. And if they do have secretions problems, we use medication, oral tablets, as well as Botox.
Thank you.
Thank you very much for your presentation. I think we need to move on to the next speaker now. Thank you.